Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. It's a pleasure to have all our professors and colleagues and guests from everywhere in and outside of Egypt. Thank you very much for coming. I welcome everyone to this session. Hopefully it's going to be a great educational session. I would like to talk about the sagittal plane knee deformity in cerebral palsy. I need to just show what we're talking about. This is a side view of a standing patient. This is the flexion gait or the flexed knee gait or stance. This is a hyperextended knee stance. I don't want to say deformity because sometimes it's not fixed deformity, sometimes it's just dynamic. And the normal standing mechanical diagram, you see that the ground reaction force normally goes in front of the knee, relying on the strong capsular and ligamentous structures in the back to prevent hyperextension, and then it keeps going up until it passes right behind the center of rotation of the hip, also relying on the strong flexors to keep the hip upright and the knee upright in a normal person. When we have flexion deformity of the knee, it's a cascade of events that makes the problem progressive. So the ground reaction force, instead of passing in front of the knee, now passes behind the knee and in front of the hip, causing, with increasing weight and growth of the patient, causing more flexion at the knee and more flexion of the hip, and more flexion of the hip causes tightness of the hamstrings and causes more flexion of the knee, so it's a cascade of events. Ground reaction force passes behind the knee, as we said, which gives flexion moments on the knee and increases the patellofemoral pressure in the front because it demands stronger contraction of the quadriceps muscles to keep the upright position. If the muscle wouldn't contract enough, the patient would fall into more flexion. So more work of the quadriceps muscle gives more pressure at the patellofemoral joint. It does give more flexion, external flexion moments at the hip joint, which causes anterior pelvic tilt, which limits the available hamstring length at the knee, which causes knee flexion deformity, okay? Knee flexion gait is one of the most prevalent gait pathologies in children and adolescents with cerebral palsy. Of course, there's the stiff knee gait, there's the Rickervatum knee gait, but the flexion knee gait is one of the most common. It typically worsens if left untreated because it causes pain, and that is a major problem. It increases energy consumption. It decreases the gait speed and cadence and step length. Fixed contracture results, even if the knee could actually reach full extension at the beginning. In a year or two, the knee could actually stick into the fixed contracture position. Eventually, you lose the walking ability, as we might see in this video. Excessive knee flexion, increasing body weight caused by the lack of movement, caused by growth. At the end, this patient cannot stand on his own or even with assistance. Risk factors for developing knee flexion gait, of course, one of them is the loss of the plantar flexion knee extension coupling, which is done by the soleus. Sometimes you lose that because of muscle weakness, sometimes you lose that because of excessive surgical lengthening of the Achilles. That's why we resort to lengthening the gastrocnemius and try to preserve the soleus as much as we can. Loss of the dynamic hip extension, knee extension coupling by the gluteus maximus. True knee flexion contractures can sometimes be the problem. Liver arm dysfunction with external tibial torsion and pes valgus, they diminish the mechanical efficiency of the quadriceps muscle to extend the knee because the knee is now into a malrotated position. Poor balance. Fixed knee flexion deformity, how to treat it, you need to correct the liver arm dysfunction. You need to address the soft tissue tightness if the problem is with tight hamstrings, true shortening of the hamstrings. The real challenge is in the older children who had already received surgery, who have severe flexion deformity as it increases with time, who are heavier in weight and have more difficulty bringing themselves up into the upright position. The presence of previous surgical intervention, especially hamstring lengthening, makes the whole area in the back of the knee in a scar state. Patella alta with over-lengthening of the anterior extensor mechanism makes you need to shorten that as well to make the contraction of the quadriceps more efficient. You need to correct at the level of the distal femur sometimes instead of going through the hamstrings again. So we accept creating an extension deformity at the level of the knee to compensate for the flexion, above the level of the knee, to compensate for the flexion deformity at the knee. So orthopedic surgeons along the way have come up with a distal femoral extension osteotomy, and it's usually not only an extension osteotomy, sometimes it's a trapezoid excision so that you compensate also for the hamstring shortening and you decrease the tightness around the knee. And together with that, you actually shorten the extensor mechanism, and that goes through either distalization of the tibial tuberosity when the child is sufficiently skeletally mature, or you go through a shortening of the patellar tendon itself and tightrope protection. Anterior physeal arrest is another technique that has been used, and it uses the natural growth spontaneously happening in a skeletally immature child. It is minimally invasive. It is reversible in the sense that you could remove your plates and allow the rebound to take over and bring things back, or you could actually use the same technique to correct what was overdone probably at the first surgery. So hopefully you don't need to reverse it. You do it only until you need it, and then in a timely fashion, you remove the plates or the tether you've put on the anterior physis. Earlier return to function because there is no osteotomy, no need for shortening of the extensor mechanism because this is a gradual process that takes place gradually, and there is concomitant shortening compensatory at the extensor mechanism. There is a lower risk of complications compared to osteotomies and circular frames. So what have been used so far are staples. I'll go through these quickly. Staples did the job until the 8 plates were invented, and the 8 plates were used in an anterior to posterior direction, aiming at fixation of the anterior physis only, and they had to be inserted through an arthrotomy. So you opened the knee, put the plates on both sides of the patella, and that resulted in anterior knee pain and crepitus and stiffness. It did do the job and achieve knee extension, as we can see in the second X-ray. PETS is a viable option, is a very good option. You do not have to go through the knee. You target the anterior physis, and then you remove them when the job is done. Sometimes it's hard to remove them, sometimes, okay? I'd like to present a mechanism that we actually published by inserting the 8 plates, but in the coronal plane. Instead of bringing them from front to back, we bring them in a coronal plane, and this publication is mainly the work of our colleague Mohammed Yahya Hassanin. He is a consultant of pediatric orthopedics at our institution, currently in Canada, and Professor Mohammed Khalid and myself. These screws and the plates are put on both sides of the knee instead of actually going through the knee and putting the plates from the front back. The screws are inserted in a coronal plane so that they actually only fix the anterior physis instead of having to put them short to stop before the midline. So the insertion mechanism, the insertion procedure is easy. Of course, you use the wires and you insert the screws. It's okay if the screws overlap a little or touch. It's okay because they both work in the same. They don't work against each other, they work together. And the main thing is to stay in front of the midline of the femur and the side view and in the lateral view. It is very important not to penetrate the trochlea, because what you see on the outer side and on the lateral side and the medial side is the cortex, but you don't know where the trochlea is. The trochlea is actually here, this line, and none of your screws should pass anterior or inferior to this line, or you will be penetrating the trochlea and cause patellar damage. This is one case where actually knee flexion deformity was present and evident. He has had previous surgery, so an 8 plate in the presence of scarring is no problem at all, and we actually achieved full knee extension and removed the plates. So do it however you can, use the technique you prefer. we now prefer the 8-plate in the coronal plane, and we are using PET to compare the results with our new technique. This study was actually based on a study, on a mechanical study we performed in the lab with sawbone, and we discovered that there is less stress over the 8 plates when they're put on both sides of the femur instead of in front, and the correction capability is more, actually, and this was cited in the JBJS. Now I would like to go to the deformity in the other way, or the other direction, which is generoricurvatum, which is not as common as flexion deformity, but it is a problem. And there are two kinds of generoricurvatum stance or generoricurvatum gait. There's the early stance recurvatum, which is mainly caused dynamically by the spasticity of the gastrocnemius and soleus. And there is the late stance phase recurvatum, which again is caused by the equinus contracture, but also augmented by the weak hamstrings, because the hamstrings at the knee are flexors, and when they are weak, the pelvis falls anteriorly and the knee goes into recurvatum. It limits the stride length and velocity, it impairs smooth transfer of momentum, and reduces the energy efficiency. It's seen in patients sometimes without prior surgery, but it's seen more in patients with aggressive hamstring release. How to treat them? Traditionally, it's a difficult problem. You treat non-operatively by using knee cages. We use the ankle-foot orthosis that is set at 7 to 10 degrees in dorsiflexion, so the child will have to have slight knee flexion with every step he takes. He or she takes the knee ankle foot orthosis to control the knee, but this would actually delay or make it even harder and slower for the child to walk. Do we use operative intervention? Of course, if you have equinus, you need to correct that, and you need to lengthen the gastrocnemius, you need to stretch out the soleus, or do an intramuscular lengthening if it is really short. You correct the bony deformity if the cause is tibial slope inversion, so you need to correct the tibial deformity. Are there other options? So far, there wasn't, and that's why we tried to implement our strategy in inserting the 8 plates in a coronal orientation, again in the back of the femur instead of in front of the femur, and we published that in the JBJS Case Connect just last year. So following the same principles, instead of using the plate in front of the midline in the lateral view, we decided to use it behind the midline in the lateral view and inserting both screws. This is a case report, actually, and these are the x-rays at the end of the correction phase, where we can see actually the screws are widely divergent, even seeing that in the lateral x-ray is evident the divergence. And this is the boy prior to surgery with a recurvatum. He had a scar of previous hamstring lengthening. And this is the same child after full correction and just before removal of the plates. It is a case, we've done a few more, but we still have to publish for the whole series when there is mounting evidence about the efficacy of this method. Sagittal plane knee deformities are common in children with cerebral palsy, with flexion more than hyperextension. Please be judicious in the soft tissue release of hamstrings when you're faced with knee flexion deformity gait, because sometimes the hamstrings are not really short. What you have to do is consider the hip flexors, correct the knee extension, the ankle plantar flexion knee extension coupling. So you need to correct the other problems prior to addressing the hamstrings, and be judicious and do the hamstrings just enough to correct the flexion gait, don't overdo it. In a skeletally immature patient, distal femoral epiphysiodesis is a viable option for the treatment of fixed knee flexion deformity and potentially the recurvatum as well. Always address the concomitant and often causative contractures. Thank you very much.